We discussed the dose area product as a quantity used in assessing the radiation risk from diagnostic X-ray examinations and interventional procedures to the patient. Now we're going to move on to focus on diagnostic reference levels and what this represents in terms of dose that your patient will receive. Diagnostic reference levels have been created as a reference guide to optimize patient dose. Diagnostic reference levels, often referred to as DRLs, promote better control of patient exposure to X-rays and is linked to the type of the X-ray examination performed. Diagnostic reference level measurements can be performed in two ways, with a phantom specifically designed for the procedure, or you can use a patient to come about the level. In general, it is preferable to use a phantom. Measurements will be taken on a broad range of equipment types. Entrance surface doses for establishing these DRLs can be measured using a TLD placed on the tube side of the patient, and it can also be determined by using a dose area product meter, or it can be retrieved from the radiology information system. The use of a dose area product meter is more practical, since the whole procedure is recorded and it is less complicated than using a TLD. The radiology information system to acquire a diagnostic reference level is rarely used because the patient weight may not always be available. Diagnostic reference level values should be obtained from performing procedures using good radiographic technique. Now, once these diagnostic reference levels have been established, it is not expected that all patients receive these dose levels, but rather that the average amount of patients examined receive something similar to the reference value. Here is a reference guide for diagnostic examinations, and this comes straight from the Safety Code 35 of Canada. The table represents ranges of diagnostic reference levels for radiographic procedures performed on adults and children. Now, they include things like fluoro procedures and CT procedures. It becomes obvious here that not all facilities will perform all of the listed procedures. Therefore, each facility should establish their own diagnostic reference levels for the procedures that are relevant to them. In order to do so, enough data has to be available. Now, the values presented in this table are dependent on the patient size. So if the facility would like to adopt this particular table, they need to evaluate whether their patient population falls within the range of patient size for the procedure. The list of reference doses for their patient population can be used as part of the facility's quality assurance program. Diagnostic reference level values should be reviewed from time to time to assess their appropriateness. It is recommended that this review is done at least once a year. So how would you use these DRLs as part of a quality control or quality assurance program? So basically, if the mean dose or average dose, patient dose that is found to be significantly and consistently higher than the suggested diagnostic reference level, an investigation of the performance of the equipment or the radiological technique should be undertaken. Also, the methodology of dose measurement should be revisited to ensure that it is accurate in determining the dose area product and the entrance skin dose to the patient. In summary, I'd like to reiterate a few points in terms of reducing patient dose, and that is effective communication is important. Imaging procedures should be explained to the patient in simple terms. If they cooperate with you, there's less chance of movement and therefore a better image that does not require a repeat and an increased dose to the patient. Patients have the opportunity to ask questions, so let them, and in this way they'll be less anxious and more cooperative. Adequate immobilization is important and is necessary to eliminate voluntary motion, especially when it comes to children. Protective shielding may be used to reduce or eliminate radiation exposure. It is used more often when we are looking at radiosensitive body organs and tissues like the thyroid and the breast and the gonads, but it should not be used if it can compromise the imaging field or quality of the image in any way. PA projections are very useful when it comes to reducing the patient dose to the breast of a young patient. So do a spine PA instead of doing it AP. We know that appropriate technical factors are equally important and that the technique chosen should ensure diagnostic image quality, but it should also minimize dose. So we should always be trying to give a higher KV and a lower MAS, because we know that the MAS is directly linked to patient dose. In order to optimize dose for patients, imaging departments should establish a QC program. A QC program can ensure standardization in techniques and the processing of digital images, and thereby reducing patient dose. A gap technique can also be used as an alternative to the use of a grid, but this is only in some situations, not for all X-ray exams. Also, we need to adhere to general safety considerations for mammography, fluoroscopy, and CT imaging. So I've included some review questions which you can do on your own. Everything you have learned until this point regarding minimizing dose to patients can be found in Chapter 12 of the Radiation Protection in Medical Radiography textbook. At the end of this chapter, you will find many review questions as well, which will come in handy when studying for the final exam. So that marks the end of this particular unit. We'll continue on real soon.